Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. The Healthy Living Series, in its 8th season, has been a lecture series held in person on the UAF campus in past summers. The COVID-19 pandemic and social distancing guidelines required that we rethink the format for the series this summer. We are delighted that KUAC has agreed to support this new format for the series as a weekly TV broadcast. Thank you, KUAC. Each Tuesday night for the next 10 weeks, KUAC will air a talk by a local health expert on a range of topics affecting your health and the health of the community. We are grateful to our speakers who were willing to be incredibly flexible in adjusting to this new format and appreciate the time they are donating to help us all live a healthier life. Before I introduce tonight's speaker, I want to let you know that you will be able to view the talks online after they are aired by going to the UAF Summer Sessions' website at uaf.edu/summer/events. I am delighted now to introduce our speaker this evening, Paula French, a nurse practitioner specializing in palliative care at Fairbanks Memorial Hospital. She will be talking about palliative medicine, specifically providing support for patients with chronic and life-threatening illness. Paula began her career in medicine as an emergency medical technician in 2006. Graduating from Montana State in 2011, Paula moved to Palmer, Alaska, where she worked in critical care and emergency medicine as a registered nurse. Returning to Montana, she worked in the intensive care unit while attending nurse practitioner school through the University of Cincinnati, where she achieved her Master's of Science in Nursing in 2016. As a licensed adult gerontology primary care nurse practitioner, she focuses on symptom management for patients with chronic illness to improve quality of life for them and their families, providing compassionate, best practice, and patient-centered medical management for the adult and geriatric population. On a more personal note, Paula, like many Alaskans, enjoys skiing, hunting, hiking, and gardening. Thank you again, Paula, for sharing your expertise tonight with us on supporting patients with serious illnesses.
Hello, my name is Paula French. I am a nurse practitioner here at Fairbanks Memorial Hospital, and I have been asked to talk about the specialty that I work in, which is palliative medicine. The objective of this discussion is to, first of all, define what palliative care is, to differentiate between hospice and palliative care. Oftentimes they get lumped into one. To identify appropriate patients for palliative medicine, understand the purpose and the goal of a consultation with palliative medicine. I'm going to talk a little bit, of course, about my role with COVID-19, palliative medicine with COVID-19, and then also we'll just end with a little case study. So what is palliative care? I went straight from the Center to Advance Palliative Care with their definition, which I think is really probably the best one. So palliative care, also known as palliative medicine, is a specialized medical care for people living with serious illnesses. It focuses on providing patients with relief from symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. And so with this definition, palliative medicine is seen as a pretty holistic approach to treatment options. Palliative care is provided by a team of doctors, nurses, and other specialists who work with a patient's other doctors to provide an extra layer of support. Palliative care is appropriate at any age and any stage of a serious illness and can be provided together with curative treatment. And so just like how you have a primary care doctor, and then you might be asked to see a cardiologist for specialty input. Palliative medicine essentially works the same way, where you would have your overseeing doctor, and then when there's additional needs, palliative medicine is then consulted. So we'll talk a little bit about palliative versus hospice care. As we just talked about, palliative care is anyone that has a serious illness. It can be used or added to the treatment plan with patients who both have the curative intent and also managing a disease. There's lots of different diagnoses that we have where we don't necessarily cure a disease. Say if it's stage 4 cancer, the goal is to live well with it. But with palliative medicine, people can continue with radiation or chemotherapy. Oftentimes we're talking about the risks and benefits of those treatments along with the oncologist to help the patient and the family understand how this would impact them. Hospice care, on the other hand, is when patients are clearly terminal. Per CDC guidelines, it's an estimation of 6 months or less to live. And when people are on hospice, then a lot of the treatments to cure or to aggressively manage a diagnosis are not used. So people cannot have chemotherapy and be on hospice. And hospice care really focuses on symptom relief, pain relief, rather than curing. The other main point with hospice care is that it's meant to be provided in a home or in a home-like setting. And so when a patient has a crisis on hospice care, instead of calling 911 and coming to the emergency room, they essentially would call the hospice nurse, who's their new 911, and they take care of whatever the crisis is in their home, hope to get them through that, and then they're there up until the very end to help relieve suffering at the end of life. With palliative medicine, sometimes people need it for a short period of time, sometimes it's years. Sometimes palliative medicine helps to transition into hospice, so lots of different ways that it can be used. With both of them, it's very much of an interdisciplinary approach. Hospice has a structure here in Fairbanks of having a physician overseeing, nurses, aides, social worker, chaplain services. So it's very much of an interdisciplinary approach. In larger areas, palliative medicine has a similar structure, but not here in Fairbanks at this time. So I think this is a helpful diagram to talk about kind of the life course. And so most important on the left side of the screen is the prevention part. Always preventing and health maintenance is of the utmost importance, but then you can see if somebody gets a diagnosis, and then as their course progresses, the need for palliative care increases as people's symptoms and their burden from their symptom increases, needing more support with their diagnosis, and then it transitions into hospice care. And then it's also important, I think, with this diagram, how we show care and follow-up after somebody passes, the health and well-being of their family members in the grieving process, and that's part of the hospice team. So patient population, specifically for palliative medicine, big kind of key diagnoses, it is probably the most common. Stage 4 cancer, anyone with stage 4 cancer, it's a life-changing diagnosis, and oftentimes they need a lot more support and help if it's identifying what are the different treatment options and what do those look like for an individual. Congestive heart failure, COPD, these are all diagnoses where curing is not necessarily the intent, it's managing the symptoms and living a really good, fulfilling life despite a diagnosis, such as those. Other times is frequent hospitalizations. That tells us as providers that something isn't going the way that we had planned. If people are coming back into the hospital, it's either that there's a misunderstanding of the treatment plan, first-line medicines aren't working, and so that's a really important indicator for us to stop and talk about what's going on, do a little bit more digging, and see how we can do better in the future. And any life-changing diagnosis. That's important if somebody is used to being able to go up to the slope or have a really active job, do a lot of traveling or something like that, and then they get a diagnosis where they can't do that. Palliative medicine can really help support these people. And then try to find out if there's a way to get them back to the functionality that is important for them. The role of palliative medicine. So a lot of it are goals of care discussion, making sure that patients have a solid understanding of their diagnosis. It's shocking to us how the conversation with physicians oftentimes does not translate into understanding from patients. We work in very specialized areas of medicine, and so we're used to using terminology and lingo along with that specialty, and so being able to make sure that we're explaining things in ways and terms that people understand so that they can better participate in their care. The goals for the treatment. So when a medicine is prescribed, what's the goal of that medicine? What's the duration of it? What are we expecting to get out of it? And then if there are adverse side effects that outweigh the goal of the treatment, then we really need to readdress that. I talk a lot to patients about what their concerns are. What are you worried about if things don't go as planned? Identifying patients, what brings them meaning and purpose to life, because if the treatment plan is not consistent with what makes a person them, then we really need to readdress what we're doing. Sometimes a recommendation, for example, may be for somebody to go to Seattle for specialty treatment, travel to Anchorage for specialty treatment, and some people say, no, thank you. I want to stay in Fairbanks. I don't have any family in Seattle. That's very scary for me. And so then it's important that we have a backup plan so that people aren't needlessly suffering just because plan A that was presented is not what a patient would want. And then also, on the other hand, talking about what maybe getting specialty care in Seattle might look like, or Anchorage. And when there's a better understanding, they may want to travel. And so being able to have time and talk these things through with patients. Acceptable quality of life, that's extremely important. Making sure that our treatment plans are inconsistent with that. Any spiritual needs, there's a chaplain at the hospital that we work with. Social and caregiving, this is always a part of my, my consultation and discussion with patients. Anytime somebody has a serious or life-changing diagnosis, there is a huge impact on the family. If they need physical care, such as help around the house or helping with bathing or dressing, changing, that sort of stuff, or if it's just the emotional stress of having a loved one who's sick. Financial resources, reaching out to our social workers in the community when there's needs identified, and then transition of care, if that's from the hospital to home, from the hospital to physical therapy, rehab type of a scenario, or transition to a higher level of care, if that be Seattle or Anchorage. Symptom management is always important to identify, and I ask that question on what's causing you suffering. Are there things that are causing suffering? If it's shortness of breath, pain, constipation, nausea, these things take a huge amount of energy out of the amount of time that we spend in a day dealing with some of these things. And so if we better manage the nausea or the constipation or the shortness of breath, then people have a lot more energy to spend on things that they want to do. There's different types of pain, and I won't get into those in detail, but we have neuropathic pain if somebody has a nerve damage, say from diabetes, or if there is a paraplegia. Psychosocial pain, and existential and spiritual pain, those are really important that we look at all of these pieces together, because if somebody is suffering existentially or having significant spiritual suffering, we know that that has direct impact on somebody's physical health, and sometimes we're not great at connecting that, so making sure that that's part of our assessment and treatment plan. Lots of barriers to palliative medicine. Number one is probably these are difficult conversations. When things are going well, I'm not usually needed for consult. If things are not going well, not going as we hoped, people aren't responding to treatments or such situations, then that's usually where I'm asked to get involved to kind of reassess where we're at in our treatment plan, and choose either a new path forward or the same treatment plan with more support. These are extremely time-consuming consultations, but they should be. These things are hard. They take time. That's usually sensitive, and people feel vulnerable. So making sure that there's time set aside to truly listen to patients. And it can be a very emotional process if people haven't been able to express their fears and concerns. Understanding somebody's, not only their diagnosis, but also their prognosis. We do so much of our information gathering from medical records, diagnostic tests, imaging, which is extremely important and has a valuable role. But it's also important to ask a patient, what do you understand about your diagnosis? Because somebody's understanding may be very different than the clinical diagnosis. And so understanding where they're at and their knowledge, and then filling in that information can provide a significant amount of clarity for patients. Asking open-ended questions, what information would help you plan for the future? What sort of things give you joy? What are some goals that you have in mind? Talking about a prognosis, depending upon what the diagnosis is, sometimes they can be very linear, and we can have a good idea of what the next days, weeks, months, years bring. And sometimes with diagnoses and individuals, it can be much more unclear. It's important to back up that information with statistics and our clinical judgment regarding what the future may hold. In Western medicine, we use statistics and information gathering and randomized control trials. It's important to look at that to have really good, solid data as far as what does the future hold, what happens to most patients, the majority of patients with a diagnosis similar to yours, what happens to them. and also talking about best case scenario and also worst case scenario, so that we're fully informing somebody and not just talking about what the best case scenario is and what we hope their future looks like. And then making sure that we're not just spewing all this information without having time to pause and get some feedback from patients. Sometimes these are such hard conversations that we need to see people multiple days, which is great because we want to make sure that we're empathetic with our responses and being very compassionate with these really difficult conversations. I know sometimes we get rather jaded, or we're in the hospital all the time, and this is very scary and new to other people. So we need to make sure to pause and recognize that. When talking about serious news, if somebody has a new diagnosis or a very life-changing diagnosis, how do we tell somebody that, and what does that look like? The first thing that I always do is to talk to the specialist so that we have the same information, and so that we're united in our diagnosis. If a specialist is able to, I always encourage them to join, and if not, then I can absolutely help give these diagnoses along with the specialists, and then talk more about the implications of it. Finding the appropriate space and also finding appropriate time, because these should not be rushed, and then making sure to sit down and take time. Making sure that we're starting from the same spot. Tell me what you know and tell me what you're hoping to hear. What have you been told up to this point, and what's the information that you're expecting to get, so that we can meet expectations. And if we can't, then we can definitely talk about how those expectations can be met in the future, or maybe the expectations are different from what the diagnostics provide. Informing. Deepening connections, these are all different techniques to provide serious news and provide an understanding for patients and their families. Very important, with the patient's permission, that sometimes family members really want to be very involved with this. The last bit there is summarizing, and so after information has been given and there's a good understanding about a diagnosis, talking about now that we know where we are, what are the treatment options, what are the future plans, and then making some concrete steps for those next treatment plans, and then summarizing all of that. We also make sure to identify social and caregiving needs, caregiver burnout. If there is a patient who has severe dementia and they need 24-hour care, and there's only one family member who is able to provide that, that's a big red flag for us. We're worried about caregiver burnout, safety in the home, financial resources, those sort of things. These are some what I call trigger questions. So my role is currently in the hospital working with hospitalized patients. So if you said, would you be surprised if your patient died within 12 months? If that answer is no, that wouldn't surprise me. We really need to make sure that there's some planning in place, and that we identify if the doctor thinks that somebody may only have about a year to live, does the patient know about this concern, so that they can prioritize and really get the most out of the life that they have? What are symptoms limiting your quality of life? What are you suffering from the most? And then can we change medications, change treatment options to better provide symptom relief? What questions do you have about the future? Is it okay if you come back to the hospital? Sometimes people get very frustrated with hospitalizations, and then they would prefer not to continue to return to the hospital. And functional status. And so once you hear out all of these things and hear out where a patient, what is working for them, what's not working for them, and what their goals are, then we can adapt our medical plan and our treatment plan in a way that is consistent with the patient. That gets us on the same team. And so it's not just optimizing a blood pressure, it's not just getting a blood sugar within a certain range. That's part of the equation. But another part of the equation that should always be considered is the patient okay with this treatment plan? Are they on board with it? What other worries do they have about it? Because if the blood pressure is perfect and the oxygen level is perfect and the blood sugar is perfect, but you have a patient that's miserable or suffering, then we really haven't done our job as healthcare providers. Here in Fairbanks, our service currently is just for inpatient consults. So if a patient is hospitalized, if it's in the intensive care unit, on the medical floor, on the surgical floor, and also in the emergency room, if there's questions on how we can move forward as a cohesive team, there seems to be conflicts in treatment options, or the treatment plan that a physician has, the patient says, no way, never would I want to do that, then that's a perfect time for me to be consulted and make sure that we can kind of pause, regroup, and be united. Most palliative medicine programs throughout the country do have a full-time physician, social worker, outpatient clinic to be able to follow up and make sure that the plan that we made is going well. Many palliative medicine programs visit patients in their home, very vulnerable populations who can't leave their homes. Some have inpatient units, and then coordinating or almost embedding with specialty clinics, so embedding with cardiology, with oncology, with a dialysis center, and so being more available. What we know nationwide from having palliative medicine in healthcare systems and embedded in healthcare systems is that it leads to a higher quality of patient care. It leads to decreased hospitalizations because it's a more cohesive plan. Patient satisfaction is much higher, quality of life is rated higher, so it's really kind of like the glue to keep everything together. And so as we look forward to the future in healthcare, palliative medicine is becoming more and more valuable, not only from a systems standpoint as far as cost savings from recurrent hospitalizations, but really from providing good quality holistic care for patients. So I thought I'd talk about palliative care and COVID-19. There has been lots and lots and lots of articles about palliative care because there's so many questions about this diagnosis. So I'll talk a little bit about that. So to add a little bit of context, with COVID-19, this is new. We have a lot of diagnoses that we have good data from, and we know how to treat things. And this is a new diagnosis that we are learning about as time goes on. What we know is that the majority of patients do very well. About 80% survive and don't require hospitalization. There's 20% of patients who require hospitalizations, and they are very sick. And we know from that population that many of them are having life-changing events and not able to return to their previous functionality, which is huge. And then an even smaller portion, it seems right now with the data, it's around 5 to 7% of patients are in the intensive care units, and that's where we have the ventilators. And so having early discussions, currently at this time, it's May 11th, I believe. Our data shows about 70 to 80% of people who are put on ventilators who have COVID-19 diagnoses, they end up dying on ventilators or having to be terminally extubated, that they do not survive. And so having these early discussions and making sure that patients know what our concerns are and also what our hopes are, that mechanical ventilation and ICU care is really amazing and can be beneficial. But if we're only talking about people being put on a ventilator and getting through it and getting home, that's really not an accurate representation of this virus. So having early discussions. Here in Fairbanks, if somebody is admitted to the hospice, admitted to the hospital with a COVID-19 diagnosis, I'm seeing most all of them to be able to say, what questions do you have about COVID-19? What have you heard? Are there things that you think we should be doing from hearing everything on the media and making sure that there's a good understanding that we're all on the same team, because there's a lot of not only misinformation, but changing information. And so making sure that everyone understands where we're at, what our treatment plan is in the hospital, what our discharge plan is for somebody going home, and then also having the discussion about what happens if things go south, what happens if things don't go as we planned, and you have a hard time breathing, so much so that we're talking about using a ventilator. Is that okay with you? Do we have permission to use a ventilator? Knowing that around 70 to 80% of people may die with a ventilator. Or if not, if somebody says, no way, I'm not willing to risk that, I would rather go home and be with my family. Visitation is extremely hard with COVID-19. And this is nationwide, is that with the virus, having family members at the bedside with critically ill patients is not recommended nationally, that there's significant limitations on the visitation of family members and loved ones. And so to have that separation, and if a patient were to say, I don't want to go to the ICU and be alone and not know what's going to happen, versus trying to just use good medical management on a medical floor without ICU care, or saying, I want to go home. Being alone in the hospital is not what I want. If I pass away from this, I'm okay with that, but I want to be with family. And so making sure that we don't have a preconceived idea of what should happen, and making sure that we're offering all the different options, saying, we think this is most likely, we're worried about this is what we really hope for. And then once patients understand the entire scope, then they can say, this is what seems right for me, this is what I'm okay with, this is not what I'm okay with. Because at the bottom line, it's doing the right thing for each individual. And those conversations take time, and so that's the role of palliative medicine. Also on this slide, encouraging advanced care planning, that's advanced directives, working a lot with the primary care providers to encourage them to have advanced care planning with their patients, especially high-risk patients. If you were to get COVID-19, have you thought about that? That's really important. And then another role that palliative medicine really has, because it's such a holistic specialty, is having conversations with families about the hospitalization of a loved one, because visitation is extremely limited or not allowed at all, making sure that we're utilizing the technology that we can, as far as video conferences, phone conferences, or a mixture of both of them, because we're used to sitting down and talking to people face to face, involving family members, and not being able to do that is not only hard on the patient and the family member, but also really hard on the healthcare staff. And so if palliative medicine can help bring everyone together and make sure that there's a unified treatment plan and messaging, then that's just of the utmost importance. So then I'll just end with a little case study here. So 68-year-old gentleman lives out in Fort Yukon. He's had COPD for many years. He's having more shortness of breath for the past couple of weeks, and he comes into Fairbanks, diagnosis of a new pneumonia. So this is kind of the very similar to patients that I see. Is it okay that he came to Fairbanks is one. How can we get you back home? Is it that you want to go back home? If home wasn't working, is it okay to stay here in Fairbanks? What kind of support do you have? All these different things. And so at the end of the day, it's doing right by people. It's understanding who they are, and what makes life important and worth living for them. And if we hear them out and if we really understand individuals, then it's been my experience that we can really bring better quality of life to people, and have much more cohesion between not only the patients and the families, but the healthcare staff. And so that's kind of in a nutshell what palliative medicine is. Normally I would open up this time for discussion and questions, and I apologize that I can't do that today, but thanks for your time. And again, my name is Paula French here at the hospital, so thank you so much.